Hello, everyone, and welcome to today's virtual family meeting on SCN2A. My name is Lindsay, and I'm a coordinator for Simon's VIP. We're so glad that you could join us, and we thank you for taking the time to participate in this virtual meeting. Before we begin, I'd like to say just a couple of words about how today's meeting will work in case you've never attended an online meeting before. Today's presentation will be shown in a window on your computer, and the sound will come out of your computer speakers. If you're having trouble hearing the presentation, please call the phone number at the top of the presentation browser window. International numbers and the passcode were provided in the confirmation email if you need those. We are recording this meeting and will share it so it can be viewed at a later date. Please be aware that in order to minimize disruptions, all audio except the presenters will be muted for the duration of the virtual meeting. If you speak, we won't be able to hear you. However, you can use the chat box at the left of your screen to ask questions, either technical or for the presenters, and only the leaders of the webinar will be able to read them. Between presentations, we'll have some time for a question and answer session, which will draw directly from your questions in the chat. Please note that our speakers are not able to provide advice regarding your child specifically, but they are happy to answer other technical or other topical questions. When asking questions, please specify which presenter your question is for, since some of the question and answer periods will be covering 2 presentations. I think that's all of the virtual family meeting information I have for you, so I'll pass it off to Carla Forbes, the Vice President and co-founder of the FamilieSCN2A Foundation.
Thank you, Lindsay. Welcome, everyone, to part 2 of the SCN2A Virtual Conference meeting. My name is Carla Forbes, and I am the co-founder and vice president of the FamilieSCN2A Foundation. On behalf of the foundation, we are thrilled to have everyone join us today. Thank you to our presenters for taking the time today to present and also gather their materials for you. And thank you to the Simon's VIP Connect for being our host today and always being a continued SCN2A supporter. Without further ado, let me pass the baton to our first presenters. Let me introduce Cora and Ari.
Good afternoon, everyone. Ari and I are going to be talking today, let me switch my slides, on developmental and intellectual consequences and autism in SCN2A. I am an assistant professor and pediatric psychologist at the Autism and Developmental Medicine Institute at Geisinger Health, and also the Simon's VIP team lead with the Geisinger team.
Hi, and this is Ari Wallace. I'm a clinical psychologist and a research scientist and the clinical director of the Bernier Lab at the University of Washington.
Great. So just to talk a little bit about the purpose of our talk today and the aim of the work is really just to understand what the phenotype of SCN2A and from a behavioral perspective and also from a medical perspective. We also want to better understand just the natural history of SCN2A mutations. And I know that's something that we talk about a lot with Simon's VIP, but a natural history study really just helps us understand how individuals develop over time. Right now, we have a lot of, we know a lot about pediatric populations with SCN2A disrupted mutations, but ideally as we gather more and more additional history, we'll learn more about what how SCN2A mutations present for individuals who are adolescents, individuals who are adults. And really this helps us to serve as a baseline to help us better understand if treatments will ultimately be effective. It's not as strong as having a randomized control trial where we have individuals who are receiving treatment and individuals who aren't, but it really does set the stage or create a baseline so that we understand when we do implement treatments, does this treatment seem to help individuals change course in their development or at other behavioral levels that we are expecting. Beyond natural history, really, that really leads to creating that groundwork towards targeted treatments and moving towards thinking about clinical trials. So our methods here, to describe a sample of individuals with disruptive variants to SCN2A, there are 3 studies that we're going to present on, and data from these 3 studies is actually going to be integrated. So one study is the Tiger study. That is out of the Bernier lab with Dr. Wallace. And then the other 2 studies are both affiliated with the Simons VIP, one being Simons VIP Phase 2, which takes place entirely online, and then also the small Simons VIP Roche collaboration, which involves some in-person visits both here at Geisinger and also at the University of Washington. In general, these visits included comprehensive in-person assessment for the Roche and the Tiger study involving EEG, as well as neuropsychological testing, and then again the parent report data from the online SVIP Phase 2. So overall, what we'll be reporting on today are 86 individuals who have a variety of variants in SCN2A and are included across these 3 different studies. There were 48 individuals with disruptive variants. So 40 were de novo, 8 de novo meaning that they were not inherited from a mother or father, and 8 with unknown inheritance. And then we also note that we did exclude individuals who had a variant of uncertain significance, which is just a variation which means that we don't quite know what that variant causes. And another important thing to note is that there is a mix of individuals who have loss of function and gain of function that we'll be reporting on today. One of the reasons that we aren't able to report entirely separately on all of them is because we do not have functional data on all of the variants. And you'll also note that the 3 different studies that we integrated the data from, the Roche study, the Tiger study, and the VIP Phase 2 study, include different types of information. So you might notice that throughout, even though we had 86 total individuals that we're reporting on the upcoming slides that Ari is going to show, there might be different amounts of people who are actually represented on each of those slides, and not just because that they're participating in different research projects. Okay, and just to briefly cover what the in-person assessment looks like, this included individuals with the SCN2A mutation, and at times we also did complete some batteries on the unaffected parents and siblings when they were available. We do have a standardized battery that when we completed at 2 different sites, we did standardize our battery across sites, and also at the Tiger study, they do use a completely standardized battery. That battery in particular, the Tiger battery, is not just used for individuals with SCN2A mutations. There are a variety of mutations that are studied under the Tiger battery, and so we note that for the Tiger battery specifically, the individuals who are evaluating the person do not know what gene event they have, if they have SCN2A or if they might have a different gene event, and it just helps us to be a little bit less biased. However, it's important to note that for SVIP and for the Roche study, the clinicians were aware that individuals were affected specifically with SCN2A. So the battery that we go through for the in-person visits include a full diagnostic battery as well as neuropsych assessment, which includes measures of IQ or cognition or developmental functioning, adaptive development, language skills, motor skills, executive functioning, as well as learning and memory. There's also some electrophysiology or EEGs performed, photographs taken, and 3D MD imaging looking for dysmorphology, as well as medical history and medical records review. And online as well, there's a parent report battery that includes some adaptive skills, as well as autism-related behaviors, psychopathology, and medical history.
Great. Thanks, Cora, for that introduction and how we gathered all of this data. So next, I'm going to present on summarizing some of the information we've gathered in regards to the phenotype, or the clinical and behavioral presentation of individuals with SCN2A. So for those who participated in in-person visits, either through the University of Washington or Geisinger, as part of our neuropsychological assessment battery, we gathered information about participants' overall level of cognitive abilities. We looked at verbal reasoning, which is problem solving based around words and language, and also nonverbal reasoning, which is the ability to analyze information or solve problems using visuals or hands-on reasoning. As you can see from this slide, some of the individuals, we were not able to collect some information or they had invalid assessments. And this is when individuals were not able to complete various aspects of the measure. For some, it might have been to some more severe or significant motor impairments. For others, it might have been language impairment, for example, being nonverbal. But we were able to, for some participants, gather or generate verbal best IQ estimates as well as nonverbal IQ estimates. So you can see from this slide, for verbal IQ, we had 7 invalid assessments. 7 were in the intellectual disability range. Those are scores that fall below 70. With 100 being considered the average. And then we had one individual that fell in the borderline range, and borderline scores generally are in the below average range, but not quite within the range of intellectual disability. And then we also had one individual that scored in the average range, or in what we consider in the normal range for that age. And then looking at nonverbal IQ, we had 6 invalid assessments. 10 were in the intellectual disability range, and none were in the borderline range or in the normal range. So we included this chart here because visually you might be able to see there's an interesting pattern. There's much more variability in verbal reasoning abilities, whereas nonverbal reasoning abilities seem to be a little bit more consistent and hovering through the intellectual disability range. So this is definitely something we're curious about and want to investigate further, but it is interesting, that variability for the verbal IQ. Okay. Moving on, so also for those who participated in the in-person visit, we were able to conduct what's considered a gold standard autism spectrum disorder assessment, which involves doing the ADOS, or the Autism Diagnostic Observation Scale, and the ADI, which is the Autism Diagnostic Interview, which is a developmental history interview we do with a parent. We wanted to present this interesting finding. In this chart, you can see participants who presented for in-person visits showed higher rates of autism diagnosis than was reported in the overall sample. And why this might be, it could be for a variety of reasons, but one hypothesis is that there might be just a lot going on for individuals with SCN2A, just having a complex presentation and more severe medical phenotypes. So in general, it just might be more difficult to diagnose autism spectrum disorder. Also, other providers in the community may be hesitant to diagnose due to these complex medical presentations. And it might just be that the most pressing concerns may be symptoms other than those associated with autism, and therefore the autism symptoms just may not be at the forefront. So that's one thing we wanted to highlight about the autism assessment. This next slide just goes over diagnostic presentation in general. So some of the various diagnoses and the most common diagnoses that have been reported thus far, and most of this information was gathered through a medical history interview that the parent completed. So overall, individuals with SCN2A disruptive mutations met criteria for some sort of developmental disorder, with most presenting with some level of intellectual impairment. And about half have demonstrated symptoms consistent with an autism spectrum disorder. Medically, many presented with seizure disorder history, sleep problems, hypotonia, which is low or reduced muscle tone, and visual impairments, which I think we're going to hear about a little bit more later in this presentation. We also just wanted to quickly highlight the seizure history in a bit more detail by breaking it down by type of seizure. So as you can see here, most participants have some sort of seizure history, but a variety of different kinds, but with petit mal or absent seizures being the most common so far. Okay, moving on to some of the behavior that we've assessed, predominantly through questionnaires and then also through some parent interviews. So for adaptive behavior, we gathered this information through questionnaires and parent interview, and we assessed a level of adaptive behaviors, which are skills that we use to get through the day and get along with others, such as communication skills like listening and speaking and writing, daily living skills like self-help or self-care skills, domestic skills and community skills, as well as social and emotional skills, so how individuals are doing with relationships and play and coping behaviors. The mean for this measure of 100 would be kind of the mean with an adequate range being between scores of 86 to 114. And as you can see here, all of the adaptive behaviors were reported to be in the low range and suggest significant challenges in adaptive skills for individuals with SCN2A across the board in all these areas. And I should mention adaptive skills or behaviors are considered when making intellectual disability diagnoses. When examining social skills impairments associated with autism, for the most part, we're seeing that children appear to be really socially motivated and want to interact with others, but the way they do that might be just a little bit different than others and other individuals with the same developmental level. So we can see from this data that social motivation, or the desire to engage socially with others, as well as mannerisms, which are restricted and repetitive behaviors, are in the average range, meaning parents reported little to no concern in these areas. Whereas cognition, or social cognition, which is the understanding of others' behaviors in social situations, and communication, which is ability to communicate with others effectively, were rated by parents to be of mild to moderate concern. And then awareness, or awareness of how others are thinking or feeling in social situations, was rated by parents to be significantly apparent or of concern. We also examined just some other general behaviors and emotional concerns through the Child Behavior Checklist, which is a questionnaire completed by the parents. All domains were in the normal range, so generally this indicates that parents are not recognizing significant amounts of challenging behaviors in their children with SCN2A mutations, and additionally children are not clearly presenting with any symptoms that may be associated with depression or anxiety, which fall under the internalizing behavior category, or disruptive behavior, aggression, or ADHD type symptoms that fall in that externalizing behavior category. We also assessed for presence and severity of repetitive behaviors that are often associated with autism spectrum disorder. Higher scores here indicate more of a problem or more severity for individuals as reported by their parent. The highest scores were reported in stereotype behaviors, which are repetitive movements or object use or sensory seeking or sensory sensitivities, as well as sameness behaviors, which pertains to resistance to change and wanting sameness in their routine. All right, I'm going to hand it back over to Cora for just a summary for you all.
So just to quickly summarize before we move into any questions that you might have, overall, our studies seem to indicate that individuals with SCN2A, regardless of whether it's a gain of function or a loss of function, as long as it is a pathogenic variant, does typically present with some level of developmental difference or neurodevelopmental disability, including intellectual disability, autism, spectrum disorder, speech-language concerns, as well as some medical concerns, including seizures, muscle tone problems, concerns with sleep and vision issues. We still have a lot to learn. There's definitely a wide range of presentations that we've seen in each child with SCN2A that we've met. Even ones with all having gain of function or all with loss of function are very unique. We are understanding more about how that type of variant is affecting the presentation, with loss of function variants being more associated with autism and the gain of function variants being more associated with early seizure activities. But we still have a lot more work to do, I think, to better understand both looking at the variants and understanding the functional impact of that variant, as well as continuing to follow families over time to see how our children change and evolve over time, because our children are all very unique and do make progress and change, and we want to make sure that we're continually thinking about them and looking about and looking at them in understanding what their unique needs are. And we have had this wonderful opportunity to talk with you today and also to meet so many individuals with SCN2A and their families. And we'd like to say that we know and understand that's largely thanks to all of you on the phone today. So thank you so much, all of you who have traveled to our site to meet us, but also those of you who have participated in our online protocol. It's very special to us to have you involved with us, and to, of course, all of the collaborators as well.
All right, thank you to both Dr. Ari and Dr. Cora. We now have some time for Q&A specifically for that first presentation. So if anybody does have any questions for Ari or Cora, you can submit those questions via the chat box. And if we don't get any questions here in the next minute or so, we'll move on to our next presentations. And if folks do have questions that they think of after the presentation, we can certainly go back during another Q&A session. Just make sure to make a note that your question is for either Dr. Ari or Dr. Cora. So we do have one question that came through. For the TIGER study, can you talk about the skin sample drawn and the future projects?
Hi, this is Dr. Ari. That is a great question. We are currently, I actually am not able to present on any of that information yet, as I'm not sure the status of where we're at in terms of analyzing that data, but the plan is to definitely do that in the future. So today the main focus was presenting on the phenotype, but I am happy to forward that question on to Dr. Bernier, and we can check on the status of where we're at with that. But I know currently we do not have any results from those samples yet.
All right, that's great. Thank you. Any other questions? All right. Well, in that case, we will just move along to our next presenter, which is Kelly Steins, and she's a pediatric occupational therapist. So take it away, Kelly.
Thank you, Lindsay. Hi, everybody, and thank you for having me. I am an occupational therapist with certification in sensory integration, and I'm the owner and senior therapist at my own practice, Occupational Therapy Consulting in Frederick, Maryland. So the backstory is that in 2013, Leah Schust walked into my office seeking OT services for her son, Ben. A year and a half later, Angie Aldridge called me to ask about getting her son Mark started in OT. And I had never heard of SCN2A, but within under 2 years, I now had 2 kids on my caseload with this, at the time, very rare genetic disorder. And together since then, we've learned a lot about how OT with a sensory-based approach can help to improve the lives of people living with SCN2A. Through my work with Ben and Mark, I was invited to then speak at the SCN2A Families Research Conference back in, I guess it was last year. And truth be told, I was a bit of a fish out of water because I'm trained as a clinician, not a researcher. But that conference taught me that our sessions are truly a living lab. And through my observations and now conversations with other OTs, we can learn valuable lessons through our sessions about what can make life easier for people living with SCN2A. I won't belabor a definition of occupational therapy because people can look that up and there's always question about what that is. But I will share that occupation means activity. And for that reason, OT is an essential discipline for understanding and furthering additional study regarding SCN2A. Activities define real-life function, and much of the research currently surrounding SCN2A is genetic or related to finding a cure, and that leaves parents wondering how to help their children learn to do daily activities until a cure is developed. I'm hopeful that OTs can make a significant contribution to supporting positive life experiences for children and families living with SCN2A, and thus help to bridge the gap between what happens in the lab and what happens at home for these special little people. But not surprisingly, we have some challenges. There are advances in genetic research and therapies happening so quickly, as I know all of you know, but they're outpacing the knowledge base of effective rehabilitation. SCN2A is one of the most common causes of neurodevelopmental disease, and it is likely that hundreds more children will be diagnosed in the coming years. OTs play a primary role in the treatment of neurodevelopmental disorders, yet many are unaware of SCN2A as an underlying cause. And the complexity and scope of clinical presentations, as has just been shown, and all of the functional challenges that are unique to SCN2A means that we as clinicians are left to infer or unknowingly apply best practice based on guidelines that may or may not be relevant to SCN2A children. Researchers are similarly challenged to translate findings from animal studies into usable human data applicable to improving the lived experience of people diagnosed and struggling with SCN2A. We do know, however, that children with SCN2A mutations may have a unique profile related to how they process and discriminate sensory information in the world and how they put all this information together. We have evidence that auditory processing, specifically from the Bernier Lab, tells us that the ability to adapt and respond to tonal shifts is unique with SCN2A. There is other literature highlighting difficulties with visual processing and the capacity to stabilize gaze, and still other research is happening into tactile registration and pain tolerance. Sensation determines experience and shapes behavior. We have to find ways to support and exploit sensation to support positive developmental experiences for people with SCN2A. Research from the STAR Institute out in Denver shows that 3/4 of children with autism spectrum disorders have significant symptoms of sensory processing disorder. If SCN2A is the most known link to ASD, it is undeniable that understanding the sensory profile of children with SCN2A is needed. While sensory processing disorder is not a medical diagnosis, more and more research is being done to show that it exists both as its own unique category of symptoms and as a related set of symptoms to many other established diagnoses. OTs who specialize in sensory processing, like myself, are well equipped to support children and families to manage the functional challenges caused by disruptions in sensation that might be related to SCN2A. But we have to support those therapists. Another thing we know is that for children, environment and the context of play strongly affects brain structure. We know that the human brain has the capacity for learning across the lifespan. Learning is a dynamic interplay of many variables, including environment, but learning definitely includes and requires sensation. Here's a visual representation of how. We know that children learn through play, and play incorporates many key developmental sensory experiences. If the auditory, visual, and vestibular systems work together, the red center being functional skills, then everything happens the way it should. When vestibular, the movement and balance system, are not working in sync with auditory or visual or vice versa, then play skills and thus a child's ability to learn from their world becomes disrupted. And here's yet another look at the role of sensory motor experiences in development. The central nervous system, meaning the brain and spinal column and all that they entail, affords sensory motor experiences that provide the foundation for all other skills. With academic learning, you can see sitting at the top of this pyramid. As an OT, I work with children of varied functional levels every day to fill those lower gaps that you'll see along the bottom in their sensory systems. No matter what functional level a child is at, they are relying on their sensory systems to support higher learning and progression through development. And when it comes to intervention, we do know that developmental intervention has advanced to incorporate use of affect or emotion to enhance integration of sensory regulatory, communication, and motor systems. And what I have learned through my work and through conversations with other OTs is that children who have SCN2A deviations are now, sorry, I'm jumping ahead. The children that I've worked with, certainly I see these patterns: motor planning, visual processing, and self-regulation, with some examples in the parentheses. So even if we try to understand more about just these three categories, we will be adding to the knowledge base about what to do and how to help SCN2A kids. And so knowing all of this, then I am proposing three potential solutions, some of which we've started working on. The first is a sensory responsiveness study, and I'll elaborate in a minute, an efficacy study, and an SCN2A OT database. With a sensory responsiveness study, we could investigate sensory responses for children with SCN2A. If we're able to develop a study that investigates physiological responses of SCN2A children in relation to sensory input, we may be able to inform or duplicate these measures in animals. The sensory challenge protocol is one way. Sensory responsiveness has been investigated previously in children, so I am in conversation with my network for how to do this with SCN2A children. This form of investigation should be feasible based on prior OT research. Replicating the sensory challenge protocol should enable us to measure things like vagal tone, heart rate, and electrodermal skin response, which would then give us a glimpse into what's happening in their parasympathetic and sympathetic nervous system. Parallel study of humans and animals may then be possible. Solution 2, an efficacy study to investigate effectiveness of OT interventions to improve human function for children with SCN2A and autism. And in this type of study, play skills would be considered a functional outcome measure of practice or motor planning and sensory processing. This is the type of study that is now being put together, and it's the place that I chose to start in regards to research because it's most relevant to my setting as a clinician and because I believe it's the easiest to replicate across settings and across clinicians. If we can access more therapists working with more kids who have SCN2A, then this type of study should be feasible, which means we need a database. Having a database of OTs who are working with SCN2A kids will enable us to create a central point of contact for SCN2A parents who are interested in clinical services. It will assist with intervention fidelity and articulating manualization of treatment for research. It'll get all OTs on the same page for treatment. It'll facilitate recruiting of subjects for further study, and it will formalize a means of data collection for dissemination to other interested research parties. The more those of us working with SCN2A children can communicate, the more we can learn about what is working and not working in the rehabilitation and in the lab, and someday in recovery of SCN2A children. So a quick overview of the current study that I'm working on is basically to answer the question, does a parent partnership model of occupational therapy with a sensory integration approach improve function for children with SCN2A and autism? The design of this study will be a single subject multi-baseline design of ABCs. It'll be for children ages 3 to 6 years old diagnosed with autism and SCN2A. They will have an identified practice or motor planning deficit as identified through standardized testing, as well as identified sensory differences through standardized questionnaire. For the purposes of this study, children should be ambulatory and have use of hands as well as some working vision. There will be pre-post goal attainment scaling and pre-post measure of what the child does with certain play objects. And then sessions will be video recorded and coded, and they'll receive treatment sessions 3 times a week for 60 minutes per session times 8 weeks. So I'm currently working on the manualization of treatment. The manualization of treatment means what distinguishes the 2 procedures that are being compared, and this is a quick summary of the key differences between the parent partnership model and a regular sensory-based approach to treatment. So in a regular sensory-based approach to treatment, the parent is out of the room, the parent is typically not participating, the therapist coaches the parent after sessions, and both child-led and therapist-led choices of activity occur. In the parent partnership model, here on the slide, I apologize, it says AR. That was an earlier term used, and I didn't edit this slide, I apologize. But the parent is in the room, the parent is participating, the therapist coaches the parent before and during treatment, and there are child-led choices only throughout treatment. This is just a list of the probe toys, and a probe is what we'll use to measure the outcomes. And you'll see that the toys that are being used will elicit varied sensory responses, or are designed to elicit varied sensory responses. And the outcomes to be measured are indicative of play skills and include the following: number of novel uses per toy or object relative to that child, which is indicative of a measure or change in practice. Number of sensory domains activated during interaction with the toys or objects, measures active engagement. Total duration of play, that the child is doing something in relation to the toys or objects, and total non-interactive play time. And then, of course, GAF goals. So the full summary of progress in relation to the 3 solutions proposed is that I've completed 2 mentorships at the STAR Institute in Denver, Colorado. For those who don't know, the STAR Institute is the lead education, research, and treatment institute for sensory processing. I'm putting together my current research team. As a clinician, as I said, research falls outside my everyday realm. I've got a lot of swings and therapy balls, but research is not in my daily swirl, so this is a big part of my process right now. I'm currently working with Dr. Sarah Schoen at the STAR Institute to put together the efficacy study, as I've outlined, and I'm in conversation with faculty at nearby universities to explore assisting and/or setting up the sensory challenge responsiveness study. And finally, the database link is live. So for those of you who have completed the registration forms, thank you. But we've only got a few, and we desperately need many, many more. If there's one thing I've learned is the power of parents in influencing their children, and that's one reason I feel so strongly about measuring and capturing the influence of that relationship on therapy. And if we can use that relationship in therapy more effectively and more deliberately, then I truly believe we can move our children or your children forward more quickly. If you haven't yet filled out requests for the forms to register your child's OT with the database, then I encourage you to do so using the link that's listed on the slide. And in summary, play is a critical component of child development, and we know play has the power to change the brain. Play provides the sensory experiences that strengthen a child's capacity for higher learning, and it is 100% possible to create, measure, and monitor sensory experiences to promote overall development at any functional level. By doing so, we can make life easier for those living with SCN2A now. Medicine adds days to life. Occupational therapy adds life to days. Thank you. I look forward to hearing from families.
Great. Thank you so much, Kelly, for that presentation. We are going to move to our next presentation by Dr. Lynne Charles. And for anyone that does have questions for Kelly, we'll have a Q&A session at the end of Dr. Charles's presentation. And just make sure to include in the chat if your question is for Kelly or Lynne. So take it away, Dr. Lynne.
Thank you. Hello, everyone. And I just wanted to take a second to thank Carla and Lindsay for having me and inviting me to speak today. I have had the pleasure of working with Carla's son, Colin, over the past 2 years, and it's been a wonderful experience to be a part of his amazing transformation that I'm going to be sharing with you today. I'd just like to introduce myself. My name is Lynne Charles. I've been a practicing chiropractor for over 13 years. My husband and I have a practice in East Hampton in Massachusetts, where we are blessed to be able to see many families. So we see people of all shapes and sizes and ages as well. So we've been able to, for the past 13 years, see many children and adults in the office to be able to help them with their lives. When Carla first brought Colin into the office it was a little over 2 years ago, I had never heard of SCN2A. And I was not aware that it was one of the most common causes of neurodevelopmental disorders. But as Carla was thoroughly going through Colin's history and explaining the different variations of SCN2A, I noticed many similarities in the symptoms that I've been seeing in children throughout my years in practice. Symptoms such as epilepsies, history of epilepsies, infantile spasms, intellectual disabilities, and autism. And other types of movement disorders as well. So some of the children had a cluster of these phenotypes, and others had only isolated traits. But what I'd like to talk to you about today is basically what a chiropractic approach to helping children with these subset of traits. I'd like to share with you what chiropractic philosophy is, what our philosophy is, how we evaluate and analyze our techniques and approaches that might be useful if you are looking to seek out chiropractic care, and things to look for, and also some results and success stories that we've had that's relatable to children with SCN2A. So hopefully I'll be able to explain a little bit how chiropractic care may be an effective tool for improving function in children with the SCN2A abnormalities. So I'd just like to start, as a chiropractor, my goal is to try to remove any interference to the nervous system that is coming from your spine, or what we call spinal misalignment. So we start with the central nervous system. Your brain and your spinal cord comprises your central nervous system. And basically, or simply put, your brain sends messages down that spinal column and sends messages out to every organ, every muscle, every cell, every tissue, every area of your body. So what we look at is we're looking at the position of the vertebrae, and if that vertebrae is shifted out of its normal alignment, or if it's not in the most optimal alignment that it can be in, it can affect the way that our body perceives or interprets the signal that's being sent. Excuse me. In addition to affecting the surrounding neurology, it's not just so simple as the bones freely moving in place. It affects the supporting musculature, the ligaments, the joint capsule, and the shock absorbers of the spine, or the intervertebral disc. The other thing that it can affect is the fluid that flows around the spine and allows for a healthy spine and communication system, which we call the cerebrospinal fluid. So I think that, the big thing is that we want the brain to be able to communicate with the body to its best potential so that we can function as close to 100% as possible. The common misconception with the nervous system is that there's typically pain associated with neurological impairments. In our, most adults that visit a chiropractic office, they're typically there for some type of a pain, whether it's a neck pain, a back pain, or a headache. But when you look at the big picture, nociception or pain reception only makes up approximately 10% of the neural activity in the body. So that means that the majority of your body's nervous system is dedicated to controlling and coordinating other symptoms in the body, which can greatly affect function rather than just simply causing pain. So because pain is not a good indicator of how healthy your spine is, we use the following subjective and objective criteria to be able to evaluate the health of their spine. Our evaluation starts with a detailed history. So we're going through with the children and the parents that come into the office, we're going through a pediatric intake, which asks questions as far back as birth with your child. This is important because we're looking for the history, any mechanisms of injury, and many people will think, well, babies don't really have, a chance to have many injuries. But going back as far as the birthing process, even a process of having an extended labor, sometimes 24 to 48 hours, can be stressful for the mom, and it's also a stressful environment for the baby. Having to go through all that and then have to have an emergency C-section, again, it's a stressful environment for both the mother and the child. Premature water breakage can make for a more stressful or rocky birth. Forceps and suction delivery can translate up to and exceeding 100 pounds of force through a baby's head and spine. Instances of cord wrapping around the baby in utero can affect the health at birth. So these are all early traumas that can affect the growth and development from a very early age. So those are all very important. In addition to the history of traumas, we do a review of symptoms, systems. We make an account of any medical procedures, any surgeries they've had, a history of medications prescribed and or taken, and also the effects or the side effects that it had on the children as well. Depending on each child's presentation, their age, their history, physical ability, that determines which objective criteria tools we will be able to use. A lot of parents will ask us what to look for in a chiropractor. What are some things to know that they're comfortable seeing children? And criteria testing is a big deal. You have to have a measure of a before and an after, or a before, a middle, and an end. And for us, we use thermography and X-ray as well as motion palpation. But for our children that can sit on their own or stand on their own unassisted or with limited assistance, we are able to utilize thermography and X-ray. So the thermography we use is a scanner. It has rollers that roll up the spine with a heat sensor on the top of it. And what it does is it measures the surface temperature of the skin parallel to the spine. The scanner gives us a temperature reading correlating to each dermatome level, which is a patch of skin that is innervated by a specific spinal nerve. This tells us if there's any nerve irritation adjacent to the spine that could indicate an underlying irritation or misalignment. So we use this as a baseline to compare to subsequent visits and evaluate change in progress. And this is just one of the tools that we use to be able to monitor change. The picture that you see here, it's color-coded. The green areas show that the temperature fell within a normal range at those levels. Yellow means that there is a mild elevation, and the elevation is shown on the upper right-hand corner. Orange is moderate, and this person doesn't have any severe irritation, but if there was, it would be shown as a red spike. The other criteria test that we use is the digital X-ray machine. We use this to take standing spinal views. So standing is really important to us because we're not only ruling out any major issues such as the pathologies, fractures, dislocations, and infections, but it also allows us to take it a step further and evaluate the position of the spine when the patient is standing on his or her own. So from this, we can evaluate why they have certain postural trends such as hip, shoulder, or head imbalances, forward head posture, nutation, counter-nutation, and rotation of the sacrum and the pelvis. We also can see on standing some functional scoliosis or curvatures of the spine as well, which I have some examples of later on in this presentation. And then actually I forgot, and the other thing that we can also evaluate is condition of the spine. So although rare in children, we can see if there are early degenerative changes or signs of erosion or breakdown. And we'll also be able to see if there are any anomalies or abnormalities, variations from the normal spine that may affect adjustments that would be administered in subsequent visits. The last criteria that we use is motion palpation. Every patient in the office is evaluated for motion palpation, for spinal motion with palpation. What this means is that we're using our hands basically to motion the individual segments of the spine, the sacrum, and the occiput to evaluate for lack of motion, joint restrictions, and asymmetries. Most of this can be achieved from a prone or a supine position, but we can also achieve it in a seated position as well. So the adjustment itself comes after we carefully review the findings in the evaluation and we determine the type of adjustment, the care frequency, and the probable outcomes. The adjustment is categorized into two different types. There's a manual or a hands-on adjustment, and then there is a instrument adjustment. The goal of both of them is to gradually move that vertebra that is slightly out of position into a better position to remove the stresses on the surrounding nerve tissue, the ligaments, the muscles, and the discs, to thereby improve the overall function and stability of the spine. The manual adjustment is, just as it says, you use gentle hand pressure in different areas depending on, again, what the evaluation, what the analysis showed. So if there was rotation in a certain area, we're going to gently push it back in the other direction. Sometimes it looks like a vibration. Sometimes it looks like just a gentle pressure. Sometimes we utilize the table. There's drop pieces on the table that can help us to move areas that need to be moved as well. The second type of adjustment is using instrumentation, the most common being the activator, also the Pro Adjuster and the KSP, which is current specific technique, which is just a tool that has preset settings that put a gentle force into the joint to move the vertebrae. So next, we're determining the care plan. Typically, how this is all based on the severity of the misalignment, the overall health of the individual, and how long the condition or symptoms have been present. Typically, our frequencies, they can start off 2 to 3 times a week, typically ending in every other week to sometimes once a month. And our care plans run anywhere from 3 months to 9 months, again, depending on how severe the misalignments are in the spine. The reason that we have the care plans is because we're really trying to, in this initial stage, we're trying to remodel the ligaments and restore a more balanced and less stressed nervous system, which can take time and repetition in order to accomplish. Just as any other health regimen, whether it's starting a new diet or an exercise program, it typically takes those repetitions for your body to finally start to fall into a more healthier pattern. So I think a lot of people are confused or perhaps nervous sometimes to bring their children to see a chiropractor for fear that they're going to perform the same type of an adjustment with the same type of force that you would use on an adult. And that's one of the big things that people ask me when they're looking for a chiropractor is well, what do I look out for? And it's typically an office that's friendly with children. The actual adjustment itself is sometimes no more than, like I was saying, a pressure or a vibration over an affected area. The babies that I've adjusted in the office, sometimes they are asleep through part of their adjustment, or most of their adjustment. So, and really, because their systems are so pure, they haven't been through the years and years of stress that our bodies have been through. They typically, parents are noticing things much quicker, such as improvements in sleep, bowel elimination, improvements in reflux. If their children have congestion or ear infections, those things are starting to clear up within weeks, typically, versus adults that sometimes will take months to heal. But next, I would like to share with you a little bit about Colin. Colin presented to us in actually a little over 2 years ago. It was in September of 2016. And Carla had contacted us and told us about Colin. He was mostly using a wheelchair at that time and wasn't quite standing on his own unassisted yet. We did a full evaluation on him and started chiropractic care on him. We started adjusting his atlas, which is his C1, and his sacrum, and we started seeing him twice a week for 8 weeks. Within a month, Colin was initiating more movement with his right hand, which was his weaker arm, trying to interact with more students, had a better balance control, and was just attempting to stand on his own. He could tolerate more sensory inputs at once, whereas before you'd have to eliminate, 2 out of 3 of the input, the sensory, to be able to focus on one area. Mom also noticed that he was being more aware of the people around him and can tolerate noises in new places better than before. At 2 months, he began standing up on his own. He could walk in the gait trainer and had noted distances of being in it for 75% of the time for just over 200 feet. At 9 months, his coordination continued to improve so that he could use a spoon and start to scoop food into his mouth. And at 1 year, he was standing for periods. He was able to stand on his own for upwards of 5 minutes at a time. So we started actually adjusting Colin's extremities around this time because he was on his feet more and using it more. So we started adjusting his ankles, his knees, his wrists, and his elbows as well. And now Colin's been with us for 2 years, and he's made some amazing strides. And we look forward to seeing even more improvement with him over the next years. We continue to check his spine routinely just to make sure that everything is communicating to the best of its ability so that his brain can communicate with his body. And we know he has an amazing team of professionals working with him to help him achieve all of these milestones. The only thing that, as a chiropractor we try to focus on is just being that missing link, or that piece of the puzzle that he needed to be able to connect all of those other wonderful skills. So just allowing his brain to connect better helped him to kind of put all of those pieces together by connecting his nervous system. I'll just open it up to questions if anybody has any questions. I'd love to answer them. Thank you.
And also during this Q&A, just a reminder that we're also able to answer questions on Kelly Bryan's presentation as well. So if anybody does have questions, just go ahead and submit them in the chat window. Okay. So it looks like we have a question for Kelly. Have you noticed any patterns in SCN2A kids as to whether they have sensory seeking or sensory avoiding behaviors?
The quick answer is yes and yes. Like with most children who have sensory differences, I've seen a mixed presentation. And I've had the benefit of having one child on my caseload who has gain of function and one who has loss of function. So I'm ever intrigued and curious to look for differences in those two, but I see a mixed presentation in both. So I've seen seeking in relation to movement and deep touch pressure, some oral seeking as well as visual stimming. But then I also see avoiding of various touch inputs, you know, really touching different sensations with the hands, avoiding wet sensations, and really any quick change in input tends to be overwhelming. And then there are visual processing differences. So I've seen both seeking of visual input, but the tendency to become very visually overwhelmed very quickly.
Great, thank you. And then we have another question. This is, can any chiropractor provide this level of chiropractic care? If not, is there a network of chiropractors available that do?
That's a really good question. That's a great question. So I always direct families to, there's it's called ICPA, the International Chiropractic Pediatrics Association, and I think the website is ICPA4kids.org or .com. And that is a network of chiropractors that are either in the process of getting their certification for chiropractic pediatrics, or or they have their diplomate, which is an additional certification with chiropractic chiropractic pediatrics. So it's the program that I'm currently taking, and I've also the chiropractors in that area are certified in Webster technique, and which is working with women in pregnancy, and also they just have more tools and more resources to work with children with more special needs.
Great, thank you so much for that. And for folks on the computer, I did also share that link out in the chat window. So the next question is for Kelly, and this is about your study. One participant wants to know, would the study be available to SCN2A patients over the age of 6?
Right now, we're targeting ages 3 to 6. Ideally, I would love to, that's one way we want to use the database, is if we can complete the study with some kids ages 3 to 6, I don't see why we couldn't expand it, given having other therapists who could replicate it. So right now, this study will only be 3 to 6 because we had to start somewhere. But I'm hoping that the database will open opportunity to broaden to, you know, whatever range is out there. Given that it's a single subject, multi-baseline design, really I think it could be replicated with any age.
Great, thank you. And this is a question for Lynn. Carla was actually asking if you can show the pre and post x-rays of scoliosis. And I think those are...
Sure. I have them in here. If I can click back, I'm going to go back to the slide. I wasn't sure how to put this in. I was afraid I was going to run out of time, but I did put, a lot of times parents ask about scoliosis and whether or not we, quote, correct a scoliosis. And I always, if you have a scoliosis, I don't make any guarantees as far as correction, but I can say that in my clinical experience, I have seen many scolioses improve over time. So I just grabbed a couple of young scoliosis patients that I had. All of these are 6-month corrections. I'm using Cobb's angle, and I'm using the same criteria as far as the superior and inferior lines. The first one is a young girl. She was just entering high school. She's 13, going to be 14, and she was checked in school in gym. Her they had the nurse do Adam's test, and they said, oh, she has a scoliosis. So her parents, who were patients of ours, brought her in to see us, and we worked on her. So this is 6 months of adjustments. She started off at 2 times a week, went to once a week, and then every other week over the course of 6 months. And not that her scoliosis is gone, but it is decreased, which is rare, because for a young adolescent female, typically the time when the scoliosis is going to progress at the highest rate is right before or right at the beginning of puberty. And so they watch the scoliosis very closely during this time, monitoring it with x-rays typically every 6 months, because this is where it's going to progress the fastest. So in this case, the young lady, her scoliosis reduced, and she's an athlete. She plays softball, and she's a cheerleader as well. This is another young lady that got a great correction. This is a 10-year-old little girl who came in. She didn't even come in for, she didn't know she had a curvature, and hers is very, very mild. Actually, Cobb's angle if it's measured under 10 degrees, is not considered a scoliosis. It's just considered a curvature, a mild curvature. So she went from having a mild scoliosis to basically downgraded to a curvature. And this, again, is in 6 months. This young lady didn't even have any issues with her back. She was coming in for other ailments. Actually, it was more for anxiety. And lastly, this is a more severe case of a young lady. Sometimes just the goal or a win is sometimes just stabilizing that curve. So again, the young lady, she came in, she was 12 years old when she first came in, and we x-rayed her 5 months later, and she just stabilized. Her curve didn't change much, but again, given that period of time and the severity of her scoliosis, she's just on the brink of actually a surgical candidate, and she, if it had gotten any worse, so she just stabilized, which is a win for the parents and for the child, because she's not progressing to surgical candidate. I hope that answered your question, Carla.
Thank you. And then another question for you, Lynn. Have you seen adjustments in extremities, particularly ankles, legs, knees, quote, replace the use of orthodontics, or are they usually done in tandem?
Oftentimes it's in tandem, depending again on the severity of what's going on. A lot of, like, for children that are delayed and having learning how to walk at a later than a typical time, usually some type of orthotic or bracing is used in addition to we're doing the adjustments in addition to that. If it's more mild, as children get older and they are more supportive on their own, and they're not, what am I trying to say? If their gait is normal and they are able to support themselves on their own, sometimes, yes, we can do adjustments, and they won't need as much orthotics, or they won't need the use of orthotics. But at a young age, typically, yes, it's just used in addition to orthotics and bracing.
Thank you. And another question came through that's also for you. What symptoms would you suggest seeing a chiropractor to address?
I am a big advocate of being proactive. So if there are any things that are going on with your children that you're not getting answers for, or if you're not getting results with, they could benefit with chiropractic. So what I mean is because it's dealing with the nervous system, and the nervous system controls everything. That's kind of a general question, but a general answer. But almost, if there are things that are just unanswered that aren't adding up or making sense, that it would be an option to check out a chiropractor. the most common things that we see parents bringing children in for are typically things like sleep issues, attention problems, stomach issues, including reflux, constipation, or diarrhea. Those are probably the most common things that we see, but it's not limited to just those things.
Thank you. And then I have a question for Kelly, but first I just want to let everyone know that might be interested in knowing how to sign up for Kelly's study. Carla shared a link in the chat window to the website where you can do that. So Kelly, this person is asking if you're able to participate in the study even if you're out of state.
That's a really good question, and I don't have an easy answer for it except to say that it's going to depend on the training and background of the treating therapist, because we would need to maintain fidelity of treatment, and both of the conditions or treatment conditions in the study require specialized training in sensory processing. So it would depend on the therapist is the easy answer, and then we'd have to look at logistics of making sure that they were able to adhere to the manualization of treatment. So it's possible, but it depends.
Thank you so much for that. And we've answered all of the questions, and the Q&A time is up, so I'm going to go ahead and now pass this off to Brenda Allaire for her presentation.
Hi, everyone, and again, I just want to say thank you to Carla for inviting me, and to all of you here for being willing to listen and share information. I've already learned a lot from the presenters who've been before me. So my name is Brenda Allaire. I am a teacher of the visually impaired. I'm working at Perkins School for the Blind, and I'm also our infant toddler coordinator. Perkins offers a variety of services, and one of the things we do in the state of Massachusetts is provide services in conjunction with early intervention to children birth to age 3 with vision impairments. So I'm going to focus today on cortical visual impairment. Just a brief overview. This is sort of the really quick version of a very complicated issue, as I know we've all kind of been doing today. I'm happy to take questions, and then if people want additional information, we can certainly chat offline. So, oh good, it worked. Sorry, I have just wanted to make sure the technology is working for me. So cortical visual impairment is actually a brain-based vision impairment. So unlike what people typically think about when they're concerned about vision issues, the CVI is really about the way the brain is processing visual information rather than any issues directly related to the structure of the eye. For people who are diagnosed with CVI, the eye itself may be normal or near normal on exam. Many of the children that we see have had a normal eye exam. Some of them do exhibit some ocular issues, most commonly an eye turn. But generally speaking, their eye exams are pretty normal. So again, this is really damage or concerns around the visual pathways in the brain. And in the United States, CVI is really one of the leading causes of visual impairment in children. As we've kind of developed more technology and more supports around the previously more common things, we are discovering that CVI is impacting a greater number of children for a variety of reasons that I will get into a little bit later. But it's important to know that this is a very common cause of visual impairment in children in the United States. So really thinking about how CVI affects children and how we think about CVI when we're looking at determining interventions. So the eye itself is what collects the information. So the first thing we want to know when we're looking at a child who has some visual concerns is whether or not the eye itself is healthy. So can the eye take in the information in the environment? And there may be some issues around that. So kids with ocular conditions, there may be reasons why the eye itself can't provide correct information to the brain. But for kids with CVI, that eye piece may be very typical, so all the information is getting in, but the brain itself is responsible for vision. And so the brain needs to take that information and make sense of it, and that's really how we learn to see the world. And there are two sort of primary pathways in the brain, and that is the dorsal stream, which is sort of what we call the what stream, and the ventral stream, which is the where. So if you think about these in terms of identifying things in your environment versus where are they, or how do I manipulate my body in space in order to access those items. And so there can be impact to one or both of those streams to various degrees, and that would really be demonstrated through a child's particular kinds of behaviors. So I think this is really one of the things I wanted to focus a little bit on. Up until 2013, American Printing House for the Blind was collecting information around young children, so birth to 3, with visual impairments, and discovered that, about 85% of children who are diagnosed with CVI have additional disabilities or impairments of some kind. And anecdotally, we knew that, but I think it's important to look at data collection, especially moving forward and thinking about research, thinking about appropriate interventions. So starting last year, American Printing House is now beginning to collect additional data nationwide through several agencies that currently work with children with disabilities or who do outreach to communities for young children with visual impairments. We expect, as that data comes in, to see increasing diagnoses of CVI, especially relating to genetic conditions. So I'll talk a little bit about, what we look for when we're thinking about CVI, but in particular, as we have gotten as a healthcare community better at diagnosing and earlier diagnostics for kids with genetic conditions, we are able to put together these pieces of genetic condition and associated visual behaviors that are concerning. So I expect that as we continue to collect data and as the data we're collecting is more robust, that we will see an increase in both the rate of CVI diagnosis and the accompanying additional disabilities. And so, these are the top 3 diagnoses that we see for children with visual impairment. ROP is retinopathy of prematurity, and ONH is optic nerve hypoplasia. Both of those are we still see them, but in differing percentages. ROP specifically has been very well treated in the United States, and so its impact on children has been decreased over time, which is wonderful. But CVI, again, is a very different type of visual impairment, and so we are still sort of in the early stages of understanding it. So there is some research in CVI, and fascinating research. Dr. Lofty Marabet, who is working with the Eye Research Institute, he works at Massachusetts General Hospital, collaborates with many people in the vision field. So he very specifically developed a type of imaging that can look at the visual pathways in the brain, and specifically for this slide, really looking at the connectivity of those pathways. And so each of these pathways that are noted here range in variation from bright red to blue. And so anything that's in that red range is a very rich and robust connection. It means within the brain, those pieces are feeding each other. They're taking in the visual pieces of information from their environment and making appropriate connections to determine those what and where pieces of information, to begin identifying important features of objects, that sort of thing. And what I think is really critical to note and sort of very interesting to me as this research field moves forward is that on the far left is a sighted control, meaning a very typical sighted young adult. And you can see those pathways are very strong. There's many of them. And then right in the middle is actually the pathways from a young adult who is ocularly and congenitally blind, so has never had vision, totally blind, and those connections you can see are really equally robust. And interestingly, what we found and what the research is starting to bear out is that those visual pathways are still being used to make sense of the environment. Obviously, not visual information, but again, sensory information. And then for CVI, so he has been testing young adults at this point with CVI just for reasons of, appropriate testing and being able to work with the children a little bit more formally. The CVI connections are very weak. So within the framework of how visual information is getting taken in, this is very, the connections are very weak. And this, again, is just mapping out that in a different framework. So the sighted control all the way to the left, those are normal, typical, what we would expect to see. And then CVI, you can see really pretty minimal connections, and you can imagine the functional impacts that might have. So thinking a little bit more about CVI and how we're looking at it in terms of red flags, these would be things that we would think about as concerning, sort of giving us a flag about diagnosing CVI. And you can see here seizure disorder and genetic conditions do fall within that red flag list. There are others, but for the purposes of this, I think those are important. And these are the 10 characteristics that really make up CVI. And so when we're thinking about diagnosing it, we look at these specific 10 characteristics and how they manifest in a young child. This is true for kids of many ages. Specifically, birth to 3 is where we're looking at these from my perspective, but the 10 characteristics do carry through ages. So just sort of quickly, I wanted to go through some of these and then think about very specifically talking more about how children are diagnosed and what appropriate criteria for that might be. So things like visual reflexive response is really just a blink response, and that is a reflex, and for children with CVI, we might notice that is absent or delayed. Color is something very specific that we look for. Many parents will report that their children really only visually attend to a single color or a very highly preferred color. Those same parents will report that their child only attends to objects that are moving or have properties of movement, that they have significant delays in bringing their visual attention to an object, that they are highly attracted to light, often to the exclusion of other visual stimuli, and that they may have visual attention in one visual field, often a peripheral field, that they really have high preference for familiar toys or objects, and are not comfortable looking at or observing new objects in their environment, have difficulty looking at distances. Something that we really look for is what we call a look away, reach pattern, which is basically that a child will visually attend to an object but then turn away before they actually reach for it. And then visual complexity is sort of one of the hallmarks of CVI and really encompasses quite a bit of information. But the thing that we frequently hear from families is that their child seems to look through them rather than at them, that they have difficulty finding even their favorite toy when it's with other items, and those sort of more complex environments can be really difficult for them. So CVI is diagnosed generally with this specific set of characteristics that are not fully explained by any ocular diagnosis the child has. It cannot be determined by current imaging techniques. Those slides earlier are some testing that's being done, but those are not currently available. And it can be diagnosed by a pediatric ophthalmologist for children, often a neuro-ophthalmologist, and for children who have seizure disorders or genetic conditions who are frequently seeing a neurologist, we will often get a diagnosis or at least a concern of diagnosis from a neurologist. The CVI range is really the primary assessment tool it's a validated tool that we use to look at how those characteristics impact a child's use of vision. So functionally, what is that child seeing? How are they taking in information from their environment? Where are their areas of need, and how can we work with the child and family to support the use of vision across educational areas? And then it provides really important information about the types of interventions that we would use to support that use of vision. These are really the sort of, once we do a full assessment on a child using the CVI range, we would determine a phase, where that child sort of scores within that range. And many young children, when we see them early, are really in what we call phase 1, which is children who are building their visual skills. They can often present as significantly visually impaired. They may have very difficult time visually attending at all in their environment. Families might report that they don't know if their child sees at all. And so really what we focus on there in terms of intervention is developing that child's ability to visually attend, providing opportunities for visual stimulation, and really building up those pathways. Children in phase 2, which tends to be preschool, maybe a little bit older depending on diagnosis age, those children are beginning to integrate vision with their functional daily skills, which might include academics or other supportive educational environments, and really thinking about routines and activities and how to support the child's use of vision within their daily life with their family and peers. And then phase 3 is really around resolving those characteristics. We are moving away from using the word resolved, primarily because those, we don't feel like those ever really go away. The children can, learn to use their vision better. We can provide lots of accommodations for them, but even children who have progressed and are using their vision well across environments often need some modifications to be as functional as possible within their environment. So that is the very quick overview of CVI. I'm happy to take any questions. I see Carla has a couple of questions on the side. She says, can you talk about how some autism behaviors are similar to CVI and how important it is that CVI and ASD therapists work together? Carla, thank you.
Brenda?
Yeah?
Brenda, actually, we're going to do a Q&A after the next presentation.
Oh, okay. Yep.
So we're going to go ahead and move into the presentation by Zahava Wilson, who's a physical therapist. And just a note for folks on the line that are listening over the phone instead of through your computer, Zahava's presentation does have several videos, and that video audio may not come through your phone speakers. So if you are listening on the phone and then just watching on your computer, you may hear bits of silence for that video audio. Don't be concerned, your audio hasn't been dropped, but just something to look out for. And then we'll go back to the questions for Brenda along with questions for Zahava at the end of this presentation. Go ahead, Zahava.
Okay, hi. My name is Zahava Wilson, and I am a pediatric physical therapist. I've been working with kids for about 28 years, and I have very much enjoyed the presentation so far. So thank you to the other presenters, and thank you, Carla and Leah, for inviting me. The intention of my talk is to talk about the idea of using neuroplasticity to make changes in the functioning of a person. So one of the methods I use is the Anant-Banyal method, which utilizes that. But I also will be just talking about general principles of neuroplasticity. So my intention is to give you an understanding of how movement can be an avenue to make significant changes in the way we, as humans, can improve function, and specifically for children with SCN2A. So, as I said, the primary method I used was created by Moshe Feldenkrais and furthered by one of his students named Anant-Banyal. And so a lot of the work that I talk about comes from her. I'm going to talk about concepts rather than specific techniques, but once you understand the concepts, you can really start to apply them right away. And these concepts can be used for a very wide range of issues, including but not limited to motor impairment, autism, brain injuries. And I'm going to use an example, Vicky, who is a child with SCN2A, and she is in the group of kids they discussed at the last symposium who had early seizures, and then the typical progression is kind of regression with age. So when I met Vicky a little over a year ago, she was really just not doing much at all. This is the first time we met. It's going to take a minute, I think, to load it. Okay, so she is kind of stuck in a primitive reflex called the ATNR here. She, at this point, was not able to hold her head up. She virtually had almost no movement, maybe a little bit of movement in her arms and her head turning, but she had no ability to really hold herself up against gravity. She wasn't seeing. She had little awareness of the world around her. Now, about a year after we've been working together. So, all the typical therapies from when she was 6 months old, and that first slide was when she was a year and a half. So here she's about 4.5. And you can see she is intrigued by the ride. She's anticipating it. She's excited by looking at it. She has head control. She has much better upright posture and strength in her trunk. One of the first things that came back for Vicky was her awareness of the world around her. So she started to recognize her parents. She started to respond to her own name. She started to watch as her family members crossed the room. And gradually, more and more parts of her are waking up and coming into play as we work together. So, how does this happen? Again, it's the idea of neuroplasticity, the brain's ability to reorganize itself by forming new neural connections throughout life. So, through scientific research, we now know that the brain can change, and even how it can change. It can form new synaptic connections. It can reorganize itself using new areas to take over damaged areas, or actually grow new dendrites. So there's really been an explosion in the field of neuroplasticity, and I have some books to recommend, which I will give you the links to at the end, or give you the names at the end. One is books by Norman Doidge, The Brain's Way of Healing, and the other is The Brain That Changes Itself, and then Anat Binyal, Kids Beyond Limits. So again, I will have those written down for you. The brain is our basic control center. It's responsible for everything we do. All of the input we get from the world goes to our brain to interpret and organize and then act upon. It organizes us entirely. We now know that the brain has the capacity to learn with the right information. And movement can tap into that. Movement can be the language for the brain. It's how early on, as infants, we learn. So just to describe that a little bit more clearly, as newborns, we start exploring the world by moving parts of our bodies, the parts that we can, and some of that is already reflex mediated, so it's already there are things we already are born with that we can do. But as we start to move around, we become more and more aware of different parts of our bodies, and then we start to distinguish them. We start to distinguish our bodies from the rest of the world, and then our arms from our trunk, our hands from our arms, our fingers from our hands, etc. This process is called differentiation. So as we differentiate parts of ourselves, we perceive there are differences. So as we move parts of ourselves, we're perceiving that there are differences in ourselves and the world. It's the perception of these differences that creates learning for our brain. So in the same way, we can give any brain information it needs to learn and to make new connections, even when that's a brain that's been damaged. However, we have to give it the information in a way that the brain can take in. We have to give the brain the information in a way that it's already geared to learn. So how do we do that? First of all, in order to change a brain, we have to meet a person where they already are. We have to connect with them. We have to connect with the child and find the impulse from inside them, rather than imposing our externally generated ideas of what they should be doing. So we can find the impulse by starting to understand, where are they able to move? How do they want to do it? How do they want to play? When we follow what they can do, the brain begins to wake up. Once it wakes up, the child begins to engage in their learning process. And we're not attempting to override what they're doing, we're attempting to enhance it. So Vicki, when we started, she could only use a little bit of her hands and arms, as I said, but she wasn't really even aware that they were there. And so gradually, we started expanding that. I started expanding what she already could do with that hand and creating play and creating more of an understanding of what that hand was, and then widening the capability she had to move that hand, and eventually she started rolling. And then from there, we just kept doing that process and adding more and more skills and abilities. When we try to fix our children, we lose the opportunity for learning. So as opposed to meeting them where they are, when we try to fix them, we prevent all the kinds of things that are happening in natural learning. So an example of this is when we do hand-over-hand learning, say putting something into a container. It's a nice skill to have, but we lose some of the opportunity for learning if we take their hand and we do it for them. So this is just an example of how this kind of learning can be better served. Not that there's anything wrong with that, but a different way that really gives the opportunity for the brain to learn is to just let them experience that through exploration. And this idea can happen on a physical level as well as other types of learning. So on a physical level with a shape sorter, or thinking through a concept, putting on shoes. We're often afraid, I think, to let our kids fail, so we take over for them and do it for them. And again, we lose all the richness that's occurring in their brains when that happens. When we meet the person where they are and explore with them without our agenda, the brain really has a marvelous capacity for change. So this is a little girl I work with who has agenesis of the corpus callosum. And what about this one? I've just put this little video in here. Oh, it's backwards. Let me go to this one. Okay, so here she is, just really exploring what is possible with this little sister. And she, she sees, well, this square can't go in the circle, and she knows how to ham it up. We've been working together for about 6 months, and she's really come along with all of her skills. And here I'm going to go back to this one and just show you there. She eventually does it without any kind of anybody doing it for her. But if we had taken her hand and moved it to that right square, she wouldn't have figured out all the different things there are involved in that, the depth, the weight, the height of the little toy there. So that's an example of how this kind of learning is so essential in kids. Once we meet a child where they are, then there's ways of engaging the brain for learning. So some of the ideas to really engage the brain are attending to oneself, movement with attention, providing input in a way that's slow and subtle, creating motivation or starting with their motivation, and providing variation. So these concepts are based on the work of Anat Ben-Yael, but I have lots of more ways to talk about how to actually apply these principles. I'm not going to have time really to go into them all. I'm just going to describe them, and I will put my email at the end of this presentation, so if you want the little packets that I have of information about ways you can actually apply them, I will be happy to email them to you. So the first one is movement with attention. Without attention, we cannot perceive differences. We can't perceive differences in ourselves or the world or our impact on the world. And if we can't perceive differences, how can we make a change? So I'm going to give you kind of a silly little example, but if I were to walk straight and walk into a wall, I would keep doing it until I perceived that there was a difference in something I had to do, which is maybe step to the side. But if I don't perceive that there's a difference in how I'm moving forward versus how I can step to the side, then I'm not going to be able to make a change. So that's something we always need to keep in mind with our kids when we want to make a change. What are they already perceiving? And how can we bring their attention to their ability to move? So this is a little girl I work with who actually has another genetic disorder. It's called CDKL5. And I put this video in just to show you how much this little girl is really attending to herself.
And
she is
sort of
very much
listening with
taking
their
in that
body.
input. And you see what I'm doing is very, very
And
subtle,
then you really
but
know
she's
something
feeling it. And I'm
is
only going to the
going
level that
in,
she herself
something is
can
occurring in her
experience. And when her
brain.
head popped up like that, she
We
just
don't
really
know
got something
exactly
new.
what
She got a
changes are
new
being
piece of
made,
information. And this is a
but
little
we know
girl
that there's learning
who is
there.
always moving, always bringing her hands to her mouth, moving around, sitting, trying to stand up. So it's pretty remarkable how she has this capacity to sit and listen to herself and attend to her own sensations. The next variable we need to create learning in the brain is slow and subtle. The brain needs to take time to take in new information. It needs time to take in new information. As we know, as learners, we don't always get things so quickly. And especially if something is very, very new for us. So if we're asking a child to learn something new, then we have to give them slow. We have to give them time. Also, the brain makes finer distinctions when it gets subtle information. So an example of this is if you have, let's say, 1,000 light bulbs in a room and you turn on one light bulb, you're not really going to notice that light bulb. But if you have 4 light bulbs in a room and you turn on one, what happens? You notice it pretty much. So the comparison is that when you really give very, very subtle information, then the brain can sort itself out in a certain way. We also need to have motivation. So a child really needs to be motivated. I had a little boy who really refused to do anything at all until I started making up stories about his feet, and now he just runs into the room and he can't wait to hear the next story. So when it seems like they're not motivated or not interested, we have to keep finding ways to join them in their interest. Say we're trying to have them play with a toy, but they just want to stare at a fly on the wall. Well, maybe there's a way to become involved in that fly and become enthusiastic with the child. Oh, look at how it moves, or just capture the attention of that fly somehow to make it even more interesting. So you're joining with them, and together you're exploring that. You're grabbing their interest. The other thing we need is variation and novelty. So if we haven't experienced something, we don't know it's possible. The action of discovering new possibilities makes other unexpected possibilities open up. So a lot of kids with autism or brain damage, they don't know that there are other possibilities, and we can give them tiny samples of something different, then they can experience a new possibility, and then the brain can create new pathways. So even the tiniest difference means that there's a new pathway, there's the opportunity for a new pathway. So again, when Vicki started using her hand, I would just vary a little bit and a little bit, and she got the message that there were other options for her. And then she began to explore more and more. So here she is. She's attending to this toy. She's really motivated by it. So it's using the principle of motivation. It's novel for her. It's not something she sees all the time. And she's paying attention to her movement because as she played with this, she started moving her hands in different ways as she saw that there was more and more available. And she saw that her action could make a difference on that toy. And a couple of days later, when I was playing with her, I just gently placed my finger in her hand, and she started grabbing my fingers and held it in a really new way. So you never know when these connections are going to happen, and they will just explode, really, with new information. But we don't really know their process that's occurring in their brain. We only can see an outcome, that something different has happened. So the overall concepts, movement is how the brain becomes organized. Movement is a key to making changes in the brain. Meet them where they are as opposed to where you think they should be. Look for what they can do. And once you've met the child where they are, then you can apply these principles of attending to themselves slow, what is motivation, or being motivated, and variation. I put this picture in here because one of my parents said This is a quote from her. I like to describe Jacob's issues as a bunch, let me start over, sorry. I like to describe Jacob's sensory issues as a ball of tangled up Christmas lights. Each time Zahava works with him, it's like she untangles a little more and a little more. So whether you're working with a child who has a fairly well-organized brain or one that's neurotypical or one that has some issues, there's always new learning available. And we can create the opportunity for our children to go from brains like this to this. I hope you've enjoyed this presentation and that it's been helpful. Let me know if you have questions. I know that these concepts, I kind of rushed through them all, and there's a lot of information, but feel free to email me. This is my email address, and also feel free to request the handouts, and I can give you more suggestions and ideas for how to incorporate these principles. And if you want to visit my Facebook page, it's Zahava Wilson Physical Therapy is my professional Facebook page and has some interesting information on there as well. And the recommended books, as I said, Norman Deutsch, The Brain's Way of Healing, and The Brain That Changes Itself, and then Anant Banyal, Kids Beyond Limits. And I highly recommend all of those. They will be very informative to tell you a little bit more about these principles. So thank you, and I welcome any questions.
Thank you so much, Zahava. So we are now going to open up the forum both for questions for Zahava and for Brenda. And we did have a couple questions come through for Brenda, so I'll start with those, but please feel free to continue to submit them. So the first question that we got, which Brenda, I apologize for having interrupted you, you started to answer, was asking you to talk about how autism behaviors are similar to CBI behaviors and how important CBI and ASD therapists should work together.
Sure, so no problem. I forgot about the Q&A part. So this is really something that's very important in the field and really trying to tease out CBI and autism. Because CBI is really manifested through visual behaviors that are observed by families and therapists or other providers, it can be difficult to sort of determine which of those things, such as not looking at faces, having difficulty in sensory stimulating environments, are really caused by a visual impairment versus, similar concerns that families see when their child is potentially diagnosed with autism. And so I think the critical piece there is if there are concerns about dual diagnosis, so kids who may exhibit behaviors sort of relevant to both of those things, that those providers work really, really well together and collaborate around strategies so that both of those pieces are being addressed in appropriate ways. And because really vision impacts everything, we want to make sure that any of the interventions being used or strategies for kids with autism take into account the kinds of vision issues that they might be dealing with as well.
Thank you so much for that. And then there were a few other questions that were submitted about CBI. One of them was, are there any CBI resources outside of the U.S.?
So they are developing resources for CBI outside of the United States. I believe Ireland has been doing some pretty substantial research and has a position paper out. I don't have that with me right now, but I'd be happy to share it with Carla, and she can, feel free to forward it to anybody who's looking for that additional piece of information.
Thank you. And then there was another question that came through for you as well, Brenda. Who would be the best type of doctor to determine CBI?
So that's an excellent question, and I think a really important one. Because of the types of things that we see with children with suspected CBI, so those specific kinds of visual behaviors, one of the first things we want to do for any child is look at ocular health. So in the case of children would be a pediatric ophthalmologist, and that person's role would be to look at the eye health, and are there any ocular conditions that might explain the kinds of things that are being seen. If those things are kind of coming back and things look really well under testing, a neuro-ophthalmologist can be an important part of that diagnostic team. We are doing a lot of work with the medical community around understanding CVI and how it presents, because it is a relatively sort of new piece diagnostically.
Thank you. And we had a question that that came through, and I believe this was again about CVI, about where families might be able to find practitioners to do the work.
So practitioners, I'm assuming related sort of to pediatrics and ophthalmology. Those would be depending on your geographic area. So what I would say is, depending on where you are, to really look about pediatric ophthalmologists at specialized centers near you.
Thank you. We also have a question that's just a general question, so I think really any of the folks that are on the line can chime in if you have any thoughts, but this participant is wondering, do SCN2A kids have any abnormal pain sensation, either super sensitive to pain or a decreased sensitivity to pain?
This is Kelly, and I have an initial thought. Pain receptors are in the tactile realm. They're touch receptors. Touch receptors are things like pain, temperature, deep touch, light touch. And so I do think that tactile processing is skewed in kids with SCN2A. And there's a pattern called low registration. And so when I said that I've seen some of these kids crave touch input but shy away from other inputs, low registration would be they're craving it. They need it. They want that input. And so I would hypothesize that in some kids with touch differences, the pain thresholds would also be different. So if they have a general pattern of hypersensitivity, then pain might also be hypersensitive. If they have a general pattern of low touch responsivity, then pain might also be low. I hope that makes sense.
Thank you. And just to go back to the question I asked before, I apologize. It was actually about physical therapy, so the question was for Zahava. Zahava, do you have any recommendations for where participants can find practitioners to do the physical therapy work?
Okay, so it really is a specific type of work within physical therapy, and you don't even have to be a physical therapist to do this work. You can be an occupational therapist, you can be a teacher, speech pathologist, you can just have any kind of background. You just have to do the training. So I have that training in addition to being a physical therapist. But depending on where you live, what you can do is go to the site for the Anat Banyal method. If you look on that book that I sent, that slide, it has her name spelled out, but it's A-N-A-T and then B-A-N-I-E-L method. And you can go to her website and find practitioners that way. You can also go to the Feldenkrais Guild, Feldenkrais Guild, and find practitioners there. You are also welcome to email me for recommendations. It's not everyone who does this work is even on those sites. For example, I am not listed on any of those sites just because I never filled out the form and sent it in. So I am happy to find people for you. And sometimes it's good to get one-on-one referrals so you can find someone who has experience, particularly with the kind of issues your child is having.
All right, thank you for that. And I haven't received any additional questions, and we've hit the 3 o'clock mark. So I just want to say, thank you so much to all of our presenters for your amazing presentations, and to everyone watching for joining us today. The recording will be available to share in just a few days, and we'll send out an email to all attendees when it's ready. I also want to extend a special thank you to the FamilieSCN2A Foundation for another wonderful collaboration with Simons VAP. Carla, Leah, and Catalina were the drivers of this meeting, and its success was thanks to their hard work. So thank you to everyone, and have a great day.